Hi, everyone. Welcome to today's virtual peer sharing and learning session, Orientation to Improving the Primary Care System in Your Local Community. We're going to give everyone a few minutes to sign in before we start. As we wait, please introduce yourself, your organization, OHT or PCN in the chat box, and just make sure you select everyone from the drop down so that we can all see who's joining. By now, I think I've had the opportunity to meet most of you, but for those of you I haven't had the opportunity to meet yet, my name's Leslie, and I'm a focal point and coach with RISE, supporting primary care improvement. We also have several new people joining today. So if you're not familiar with RISE, we are a free resource for OHTs and PCNs with a specific purpose of supporting them as they develop and mature. So over the last few months, myself and our head coach, Mike, have met with many of you to understand what you would find helpful from us in a program. And so one of the elements we're sharing with you today is just on the slide here. So this is meant to be a space for you to post your questions to peers, to post your questions to us. And we also post resources here between sessions. So as rapid synthesis are available, or as a briefing note is available, as well as partners are participating in this as well, like PGLO. So you can use this as a space to post your own resources, leverage resources from different expert groups, and post your questions. And we always say, ask your question. If you're not sure if we can answer it, we will work with our partners to find someone who can. We also heard through these interviews that we had with many of you that you'd like to keep these sessions to an hour instead of an hour and a half. So on that note, continue to introduce yourselves in the chat box, but I am going to turn it over to our head coach to start our session today.
Great. Welcome, everyone. Thanks for attending and taking time to join our webinar. I'll just do the land acknowledgement very quickly. As we meet here today, we're in solidarity with the Indigenous people of the Turtle Island and would like to begin by acknowledging that the land on which we gather is part of the treaty lands and the territory of the Mississaugas of the Credit, and before the traditional territory of the Haudenosaunee, Huron, and Wendat. We also acknowledge that many First Nations, Inuit, and Métis peoples who call this area their home. We are grateful for the opportunity to be working on this land. Let's go to the next slide. So the objectives for today, this session is for OHT leads and PCN leads, and in many cases, ED leads. It might be leading large group practices to help them achieve their TPA, their deliverables in terms of the work that they're doing for OH and for the ministry. And what we're trying to do is to help you understand how we can advance local primary care access and attachment and improving primary care aligned with Ontario's Primary Care Action Plan. So we want to understand the key drivers for improving primary care that enables better attachment and building better IPCTs, interprofessional primary care teams, learn through a real life example from Huron Perth family or OHT today, obtain a shared understanding of some terms that are flying around out there, and then also learn about RISE supports in terms of how we can help you with this work over the course of the next year. Let's go to the next slide. So beginning this fiscal year in April, we wanted to understand how we could best support the OHTs and their PCNs. And so we reached out to all 58 OHTs and to interview them and ask them what would be useful for them during the course of this next year. 34 of the teams responded. We conducted interviews anywhere from half hour to an hour. And on the right there, this is what we heard from all of you, that there was a real interest in primary care system change, but more how-to and very practical replicable examples. We wanted to hear more about building and sustaining primary care teams themselves. That is, how to make sure that there's a teamness and they're actually functioning as a team rather than just necessarily co-located in the same spot. How to engage primary care providers during a time when primary care providers are extremely busy, have an awful lot of work to do and are really the center of the integrated care work that's being done across the province. Wanted more information about attachment and access within primary care operations, data for population health management and equity across various primary care models, how to build relationships, how to also take this work and scale it so that they can spread it across the province. And where does digital enablement fit into all that? How do we make sure that our information systems are supporting this? We also heard that that folks did not want these sessions to happen over lunch, and so as a result, we've switched them from 11 to 12. Let's go to the next slide. So in general, what we'll be doing in the course of this next year, we'll continue to do these monthly peer sharing and learning sessions, the one that you're attending right now. We'll organize them a variety of different ways in terms of how we actually do them. Some of them will be more didactic, some will be more case studies, and following those sessions, 1 week later, we'll have what's called peer problem solving sessions. And these are sessions where people register to come and actually work on issues that were elaborated on in the previous week's peer learning session. So it's really a problem-solving group. There's very little didactic, but it is facilitated by RISE to help solve some of the problems and barriers that you might have when you're trying to improve primary care systems. And the two coaches, Leslie and myself, will be available to support working groups, primary care working groups that the OHTs or PCNs put together. And those kind of supports can look like ad hoc guidance. You can send us emails with questions, whether you're looking for resources or answering specific questions. We can also sit on some of those working groups and help provide a population health management lens, as well as our expertise in primary care improvement. Let's go to the next slide. Right now, this is what our timeline looks like. We have today's session, which is an orientation to how to begin thinking of improving the primary care system at your local level. For July's peer sharing learning session, we're looking at how do you stage the work? Is there a sequence to how you go about doing this work, and where is the best place to start? August, we take a break typically because most people are on vacation. And then we have placeholders right now for September and October around engaging primary care and also planning local staffing models. How do you put teams together? And the potential topics for subsequent months include improving access, integration of primary care and specialty care, specifically maybe with respect to ICPs, but not limited to ICPs by any means, and also how to build trust and how to enable spread and scale. Let's go to the next slide. So here, I just want to spend a little bit of time talking about what does it mean to improve primary care at your local OHT or PCN. Let's go to the next slide. But before I do that, I just want to address the sort of array of different labels that you're hearing out there, whether from us, whether from the ministry, OH, or other OHTs or PCNs. We're hearing all sorts of things like health homes, neighborhood models, patient medical homes, high-performing primary care, neighborhood health homes, us today talking about improving local primary care systems. We're all talking about the same thing here. These are not different things. It's all about how do we improve primary care that sits at the center of our integrated care system in Ontario, and how do we make sure that primary care can do the best work it could do to manage its patient populations while coordinating and integrating care across the healthcare system. So I just wanted to clear up some of the terminology issues. Let's go to the next slide. Want to make sure that realize that the work that we're doing, it's grounded in the Primary Care Act. The 6 components of the act are that the work needs to be province-wide. It needs to make sure that insured people are connected with care, not only healthcare, but with social services. People need to be able to get to it easily and have easy access. It needs to be inclusive, and equity issues need to be, or inequity issues need to be addressed. Patients need to be empowered to take care of their health, because they're only in the system 1% of the time, and 99% of the time they're taking care of themselves. And it needs to be responsive to its communities. So just want to make sure that we understand that part of the work that we're about to show you is based in the Primary Care Act. Let's go to the next slide. So with the Primary Care Act and with what the research literature has told us, this is what we're talking about when we talk about improving primary care systems. We've looked at work by people like Tom Bodenheimer in the US, Barbara Starfield, and others that have tried and working on improving primary care systems. So on the left-hand side, what you have is our principles. This is what we're trying to accomplish. We're trying to improve primary care to ensure that it is all of those adjectives there: continuous, collaborative, accessible. You can read the whole list there. The critical part is on the right, and these are the drivers that contribute to an improved primary care system. So we have to have interprofessional team-based care. And for those of you that have been to our webinars before, you know that in January through March, we did a series of sessions on what does a team-based care look like? How do you get people to work to the scope of their practice? How do they function as a team? How do they create teamness and manage populations of patients? You want to have relational continuity, which including attachment. And when we say relational continuity, what we're talking about here is want to make sure that the patient sees the same provider team, if not the same provider team when they come in for care, because the research literature is pretty clear that the better continuity of care, the better health outcomes. People need to have timely access to care. So again, that's coming straight from the Primary Care Act. And population health management approach, which we at RISE have been talking about for the last 5 or 6 years. How do you look at a panel of patients and think of them as a population and manage their care, not only from an individual standpoint, but from a population standpoint? We need to make sure that patient partnerships are engaged in our work. Many of you have PFAC groups already, and make sure that there's community engagement. And by community, it's not solely just the healthcare system, like the tertiary care system or specialty care, but it's the social services too that need to be engaged. We want to make sure that the OHTs and PCNs have performance measurement. There's clearly a performance measurement that comes with your TPA from OH, but you might have specific work that you're doing that needs its own performance measurement, and that you're using QI approaches and continuous learning approaches to make sure that you learn from the literature, but as well as understand how you're impacting the care by collecting data appropriately. There needs to be good leadership and accountability and governance. And while that's not necessarily a strong suit of RISE, we are partnering with the Align folks who can help with governance and leadership issues. And then there'll be finally the digital health piece. How do we make sure that we get information from our electronic medical records? How do we make sure information transfers timely and appropriately from hospitals to primary care, from long-term care to primary care, so on and so forth, so that we can make sure that there's good communication. And many of you have been working on e-referrals already and working with Ocean towards some of that work, as well as data analytics. Let's go to the next slide. So this is very busy. Don't worry about reading it. We're going to supply these to you. This is part of what I wanted to point out around how RISE can support you. So within each of those 8 categories that I just showed you on the previous slide, if you look inside each one of them, they become an aim statement or what we're trying to accomplish statement on their own. So one of them was around interprofessional team-based care. So we could say that what you're trying to accomplish is to create a high-performing primary care system that pursues team-based care, where team members vary by the population needs, but also including non-clinical staff. So for each of those, there's also primary drivers. You need to coordinate care across all conditions and make sure that there is chronic disease prevention and management built into the system. You need to coordinate with specialty care. Health and social services need to be involved. All team members need to work to scope of practice. So if we just even follow one of those drivers along, coordinated specialty care, one of the secondary drivers that's important to coordinated specialty care is creating intentional processes to facilitate communication with specialists. And that's sort of a wordy way of saying good referral processes between primary care and specialty care, where both primary care and specialty care get their questions answered, information flows appropriately, the patient goes to specialty care, is stabilized, and returns to primary care with clear education and instruction about how to maintain their health. And some of the strategies might be to have specific referral process agreements or convene opportunities where specialists in primary care can see the patient together. So just some change ideas. So this is the kind of work that RISE would support the teams with doing. We have driver diagrams for each of the 8 building blocks. The strategies and the secondary drivers and strategies are not completely comprehensive. They're the main ones that come from the literature. And also we can help you with measurement strategies that are associated with the changes that you're going to make. So it looks a bit confusing, but it's actually, if you think about this, this is really a change package for how you would go about creating team-based care. Let's go to the next slide. So the other thing I wanted to point out is when we're interviewing teams, they said, is this new work that we have to do? Because we've got a ton of work to do already. And what I wanted to point out was that all of this work around these primary drivers is associated with the current work that you're doing and associated with your TPA deliverables. So beside each of the 8 boxes here, there are some examples of how it is tied to your work. So when we think about interprofessional team-based care, your past and current work on leading and coordinating submissions for IPCT funding is supported. When we think about relational continuity, developing relational continuity within the primary care team continues to support or continues to help you with implementing supported attachment. Population health management, it helps you increase participation in cancer screening, including supports for unattached participants that are trying to access screening. So each of these primary drivers in one way or another attached to your TPA deliverables. So this is not new work. It's just helping tie all of your work together in a system that helps you move forward with not only creating an improved primary care system, but meeting your TPA deliverables. Let's go to the next slide. Just an example. So, if we start thinking about the drivers together and how this impacts your work, if we take population health management and we think about how you're building a system of chronic disease management, and you couple that with a high-functioning interprofessional team-based care that is connected to its community, whether it's specialty care or social services, and partners are informing that, what that ends up equaling is increased access and the ability to attach more patients. So an efficient primary care team that's doing population health management tied to community resources creates a space and time for primary care teams to add more patients to their roster. Down below is an example of caring for complex older adults. So we look at the population of complex older adults. We engage with the primary care team engages with geriatric medicine, either embedded in the team or a good specialty relationship with geriatric medicine. They may do biweekly roundtables to talk about specific patients, shared care approaches across team members. They make sure that there's a strong connection with community resources, for example, the Alzheimer's Society or dementia societies, and also community and home care. All of that resulting in PC capacity building to be able to manage those patients more effectively rather than them consuming a lot of time through surprise visits, that sort of thing. But that person-centered approach gives you a more flexible opportunity to improve access for other patients that might come onto the panel. Let's go to the next slide. So what I'd like you to do is, for those of you who don't know what a chatterfall is, we like to be able to get your feedback on what we've talked about today. And in a few seconds, I'm going to say go. And what I'd like you to do is just type very quickly a phrase in the chat box around what do you think needs to happen to make this model come to life or to make this work come to life. So let's just think about that for a second. What do you think needs to happen to make this come to fruition? And we'll do it in 3, 2, 1. So type something in the chat and just enter it. Wonderful. Lots of stuff coming in. Terrific. Very helpful. Thank you. Still a few more coming in. We'll make this available to you afterwards also. We'll be able to show you what others said. So clear governance, yep, lots of great. Okay, thank you. That was very helpful. So what we want to move to next is we're going to hear from the Huron-Perth and area OHT. We have two presenters, Joelle Lamport-Lewis, who's the director of Huron-Perth and area OHT, and Robin Spencer, who is the executive director of the Listowel Wingham Family Health Team. And they're going to talk about how they've been building their integrated primary care system in the Huron-Perth area. Following that, I will have some questions for them, but also there'll be time for you to ask questions of them. So you can either type your questions in the chat or raise your hand, and I'll be happy to call on you to get your questions from you. So Joelle, I believe you're taking off first. Joelle's been having camera problems, so we won't be able to see her, but we will be able to hear her. So take it away, Joelle.
Yeah, thank you, and apologies. It's perfect timing, right, for camera issues. I'm going to pass it over to Robin to actually start walking us through our population health work. Thanks.
Thanks, Joelle. So thanks so much for having us. I think I'm going to start out by kind of giving you a bit of who we are and what our sort of landscape is in Huron and Perth. So our counties are about 400 square kilometers. So fairly large geographic area, although not compared to our northern partners. We're really fortunate in that we have 8 family health teams and a CHC in our area. And really only 2 physician organizations that are not attached to a family health team. So we're really very fortunate to have gotten sort of when family health teams were established. We were lucky there. So we're kind of we do really have that advantage. We have a reasonable complement of primary care physicians, although a lot of them also do hospital work. The overwhelming majority, I would say, are GP anesthetists or work in Emerge or do OB. So a lot of our primary care providers are not only doing primary care. So our attachment rate is actually relatively high, though not all of those 93% are people who actually live in our area, which creates issues both for primary care in terms of ease of doing the work and efficiency, and also things like ED utilization for things that could be handled in primary care. I would say it's probably higher in our area than in other areas, because if you live in Goderich on Lake Huron, but your doctor is still in Milton, where you moved from a few years ago, you go to Emerge when you need something done versus driving for half a day. So we have that sort of issue, but we do have, like I was saying, a lot of different primary care programs, everything from foot care to clinical nutrition, diabetes management. We have sort of the standard basket of services at all of the family health teams for team-based primary care. We don't have a lot of after hours clinics, mostly because, well, not mostly because, just because it is smaller communities, so it's harder to have that critical mass, but also typically with how the FO agreements are set up is there's an obligation to provide after hours care unless you also do hospital work. And because so many of our physicians also do hospital work, they don't do the after hours care because that just wouldn't be reasonable from a workload perspective. But it does leave, there's a lot of like, well, why don't we have a walk-in clinic kind of discussion in our community? So, which is not where we want to get to in terms of that continuity of care that Mike was talking about. We did receive funding through the original EOI funding. So that first round of funding, before everything became all about attachment, we did get some funding the first time around. And with that, we established what's called our unattached care clinics. So at 4 different FIT sites, we hired nurse practitioners and nursing in order to provide sort of interim care for people who don't have a family doctor but live locally. So really great uptake there, like over 6,000 patients, 7,300 visits. So, and in those clinics, we really saw everything from, just someone who needs a monthly allergy shot to really complex patients where we really had to draw on community resources to support them. So we're about 21 months, almost 2 years into the unattached care clinics. And I'd like to tell you that we're really smart in terms of like knowing and seeing the future in terms of attachment and having a supported attachment strategy. We didn't really know at the time, but now we're in a really good position with the supported attachment sort of funding coming through, at least in the short term, to integrate that with the unattached care clinics. So we can proactively get people on that attachment care pathway, but have somewhere close to home for them to receive interim care and then get some stabilization. The physicians know who they're going to be rostering, which kind of makes it more appealing to them. So we're working through the logistics of that because it's much easier said than done, but it's I think going to work out well. Logistics to sort out there. So you can flip now, Leslie. So our end goal is we've landed on trying to have sort of 3 different health or neighborhood or neighborhoods, I guess you could say, across the 400 square kilometers that we cover. So we'll have basically in each neighborhood will be a core basket of services, including medical homes, which is our existing primary care teams. All of the primary care teams, I mentioned to the 2 FOs who are not attached to teams-based care, and we were successful in the most recent, like, second round of funding, in securing funding that will allow them to have teams-based care, like, co-located with them. So that'll be really great. So we're working on our focus really is the medical homes, and there's tremendous pressure right now on attachment. So that's really where the focus is. But the broader vision then is to plug community care in, and do that evaluation to make sure each of the neighborhoods has all of the resources that they need, in order to have everyone attached, but also have it not be all about us in primary care, in the medical home, but have it be much broader. Yeah. Oh, so let me see if I can answer a few questions that come up. So to drive from Tavistock, so down there in the left-hand corner, to Goderich is probably about an hour and a half, 2 hours, depending on traffic. Mhm. And that's in the summer. In the winter, it's a whole other ball game that I won't even get into. But yeah, yeah.
Yeah,
Are
and
there
from
any other questions you'd like answered? Go ahead, Joelle.
no, I was just going to say driving time from end to end is just under 2 hours in our region, depending on which direction you're going in. But for the neighborhood model perspective, this model was created with the idea that we would be within 30 minutes of travel time to any neighborhood.
Yeah. So, and we've also aligned it to a certain degree we have a lot of small hospitals, like there are 8 hospitals in our region as well, and they're kind of grouped as well. So we're, for the most part, sort of aligning that as well. There are a few exceptions, but it kind of, each community, I don't know, those of you who work in small communities, each community has their own, like, healthcare ecosystem in it in rural Ontario. So we're trying to kind of leverage that as well, because there are a lot of really great, strong partnerships as we're trying to look at what belongs in primary care, community care, and acute care. So let me look at, okay. Yes, there are a
What I'll
lot of
have you do,
hospitals.
yeah, what I'll have
Yes,
you do,
you're good.
Robin,
Yeah,
is go the two of you go through the slides, and then we'll come back to some of these questions here,
great.
just so you don't have to stop.
Perfect. Right. So why don't we flip to the next slide then? So I haven't personally always worked in primary care. I've worked in acute care. I've worked in community mental health and addictions, and then eons ago in the private sector. And it's always been a bit of a mystery to me as to exactly what belongs in primary care, what's community care, and what's acute services or specialty care. And it's especially kind of tricky in rural settings, because in order to get the critical mass to run a program, like, sometimes what could be a community or primary care program has landed with the hospital because it has to be accessible to everyone. So what we're trying to reimagine here is what belongs where, especially given the financial pressures that hospitals are under as well, where they're really having to have a hard look at what services they're providing and what they're funded for and that kind of thing. So what we're trying to do is really define that. So we'd have our neighborhood networks, so those 3 networks, and really try to have centralized access and navigation. And really that navigation function is really the big one. So we don't have clinicians trying to figure out how to get their people where they need to go. Then within the medical home, that's really where a lot of the upstream chronic disease management and even prevention happens. So I'm not going to read through every single one here, but we really want to have either embedded in the teams themselves, or as part of the family health team or the CHC, or a very direct link. So for example, a lot of the family health teams, in collaboration with their FOEs run Mint Memory clinics, and we have the Alzheimer's Society participates in those clinics. So we have some of those models already set up where we have community organizations like actively participating in case conferences. So we'll build on that. And then we do want to look at the community-based services and really do an inventory to make sure that what can happen in the community is happening, and that access, equitable access close to home is happening, especially because we've got really great partnerships with local pharmacies, and we've seen like the province wants to push as much of the stuff that doesn't need to be in primary care into places like pharmacies, and then obviously leveraging things like community paramedicine, because we have, people who can't actually even make the half-hour trip that Joelle was talking about with the model for various reasons, that we can leverage those partnerships to provide care, like literally at home. And then, of course, the acute, our local hospitals, and then tertiary care centers as well, where people do that. Like, we're never going to have a neurologist in here on Perth. We don't need that, but we need a clear care pathway when people need to access it. So that's what we've got so far in terms of who's going to be accountable for what care and how we're going to envision it. And I will say one of the things that has enabled us, I think, to get so far, and maybe I should turn it over to Joelle. I might steal her thunder from the next slide, but I do think we've had really long-standing partnerships for a long time, and we're kind of a nice size, sort of big enough to do things, but not so big that it feels like we're kind of like trying to steer the Titanic kind of thing. So, yeah. So I'll stop here. Joelle, if you want to take over.
Yeah, that's great. Thanks. And I think I'll highlight pretty quickly through the next few slides some of what Robin has already touched on. But we're building from healthcare system strength, not starting over or recreating or duplication. Equity and standardization, things like that will allow better access and clearer pathways is really where we're going. So a critical starting point for us, this region already had strong foundations in place. It had a culture of collaboration and working together. It's robust team-based primary care that already exists, demonstrating success with hub-spoke node models and around heart function work, cardiac rehab, lactation, and this goes to one of the questions in the chat as well. But our neighborhood models, we have one lead FIT or CHC that it takes the lead on that work. So it might move from a FIT to FIT, but that there's that sort of centralization and process mapping that exists. We have clear lines with provincial directives and with primary care action plans to deliver on these things. And we had strong clinical engagement in the inception of the OHT. So that certainly is allowing us to progress forward perhaps faster. And we're getting stuck on a few debate issues that we've had even last night in some of our meetings, but they're good. They're great conversations at the right place. So it's a lot of excitement around that and working together. So it's not a redesign from scratch. It's about scaling what we know what works and connecting it and being deliberate and effective. Next slide, please. Some of the key challenges and approaches certainly aren't new. And we look at this as the OHT from a system-wide lens, of course, and around that coordination aspect. So like many regions, these are familiar pressures. The fragmentation in our workflows, variation in services, inequities across rural regions, ensuring access to care, whether it's progressive in what that care is needed, and having to leave the region, but really trying to optimize what services are available and what services we need to then bring into the region, given our aging population, for example. We're also seeing growing demand, and particularly in the aging and mental health, that is causing a lot of pressures. We're hearing all the time about administrative burdens and things like that. Shifting to that solution, our response is not about adding layers. So we're not looking at a physical infrastructure that is then doing this work. It's really that sort of identification of who's doing what where and clear pathways to execute. It includes centralization of intake, navigation, standardized pathways, and better use of digital tools, and more consistently and agreed to measures. So even our clinical group last night was talking a lot about whatever we do here, we have to do in another area as well. So there's some of that standardization. Strengthening our chronic disease management, because we're seeing that in our population health numbers around increased numbers. So really trying to look, those 5 years out, what are we building for, and what do those pathways need to be at the same time. So it's about solving system problems at a system level. So no individual providers are carrying that burden alone, for example. Next slide. A little bit about our methodology and phased approach to this. So evidence-informed co-design, phased for success here. So this work followed a structured evidence-informed process grounded in both local data and engagement, as well as provider input, service mapping, population health data, and understanding our current state of and opportunities. We move through 5 stages of discovery, design, implementation, deployment, and long-term transformation. So we're in the middle of those stages. Implementation was based on starting with the readiness. So who's ready for what, where, and identifying who wanted to lead and move to a more integrated approach, and then the rollout across the system and scaling through that. So we drew on leading international models, the Netherlands in particular. Singapore was another one that we really leaned heavily on around where access and attachment approach would be. And in our rural region, we really wanted to be very mindful of, the pressure of attachment, sure, but also in that we're looking at that longer term plan around, so attachment means what around access, because we know that the challenges that we have in our region to be able to actually, not only attachment is half the battle, but then how do you actually have somebody be seen when they need to be seen? Next slide. And then just wrapping up, or actually passing it back, I guess, to Mike.
Great, thank you. The chat is absolutely loaded with questions, so I'm just going to ask one, and then we'll try and get through some of the ones in the chat. When you were doing this work, I know you started from a strong base of primary care, but many of the OHTs may not have that strong a base. What would you say to them about engaging primary care in this work? What is the attraction to do something different when primary care is so overwhelmed?
Robin, do you want to start, or do you want me to lean in?
Sure. Yeah, I mean, it kind of came down to sort of the basics of change management, where like understanding that there will be people who are resistant to change and just generally cynical, which I think we see fairly often in the healthcare system, and rightly so. And then those who want to see somebody else do it first. So I think a lot of this got started with the original EOI funding and the unattached care clinic. And it basically, we said, who's willing and who has the space, and okay, we're choosing you. It was a little bit more complicated. We needed geographic distribution and needed to make sure that there was an unattached population, but that's really how we got started. And so kind of taking the coalition of the willing was really one of the key things. And then just demonstrating value early. There were a lot of naysayers. Like, I won't tell you that everyone's like, this is a fantastic idea. Like, I went to a lot of meetings to justify what we were doing and did a lot of like, I understand your concern and we're going to do it anyway and it will evolve and that kind of thing. So it takes a lot of that, like, just general, like, we have a vision and we're going to keep going kind of thing. And for the most part, I think that did help us build momentum towards fairly strong buy-in, I would say, Joelle, that we have from primary care and the physicians primarily. Like, that's the big one. So I don't know if you would add anything, Joelle.
Yeah, only a couple things. Just that, asking for their input. So asking for them, even though the vision was needed and they needed to see that vision, asking for their input, and but not from the perspective that it's going to limit us if they don't like something, but that that their input was really important. So even the naysayers, as Robin had pointed out, they were really helpful in shaping the model and helpful in understanding what is needed. The other piece is that when we're talking to clinicians, they're busy. They're very busy doing really good things. And so if we can help them in other ways, and we built that trust within that dynamic, you can, like Robin said, it's the momentum of the willing. You're going to see that, and that conversation between clinicians and having those opportunities to meet and have space for them to have the conversations about, well, what about this and that type of thing. So giving enough of line of sight of where you're going without really having it completely painted, that things are going to change and evolve even as we roll out this plan now.
That is terrific. We'll have to make a note of those points because I think the "what's in it for me" message is really critical, and certainly what we've heard at Rise is that time is I need more time. I need less paperwork. I need to be prepared for who's ever going to be in that exam room because I don't want to be surprised. So this is great listening to this. Rob, you typed lots in the chat. I would just want to give you an opportunity to ask a question or comment first. Rob's our co-lead at Rise.
I just, just congratulations on this. This is just a heap load of work in building trust and building those processes. It is a model for many in Ontario. So congratulations. And, it's almost very understated. I know that the amount of work that you said that's got into this, but the strategic planning, the real thoughtful approach, the importance of the co-design, the engagement, all of it goes behind your success in this area, with your vision around bringing people into a high-performing primary care team, so that and attachment is really your only first step on that. That's clear in your presentation. Just a real quick question about your information strategy, about how you're thinking about that in your EHR strategy in your OHT and PCN.
Yeah, so I'll start with just a bit of a high level from a system perspective. So, we sort of went through that process of, everybody has to be on the same one and they have to do it this way and that type of thing. What we've really realized, and just merely the fact that we won't be able to afford any of it. And so how do we think about those data or those lakes where we can make the connections between systems, either through a digital function, an AI function, or a human function? But how do we bridge between all of our different EMRs and our systems that are happening? And we have done a mapping. It looks like a total spider web of all all the systems that we have. And we know where they are and how they talk to different sectors. We've mapped out community support service sector, all like mental health sector, hospital, primary care. So we have a really good idea of where those things are and then what are those bridging functions. But as people are starting to develop, we have to pick new EMR, then we can say, hey, these are the 4 that are the most popular in the region and that type of thing. And then whatever they choose, then we are working really hard at connecting those systems. So not trying to unaffordably try to sort of do it all at once, but just trying to really hone in on where we can connect the dots. And that's where the OHG can be really, I think, most effective within system change work. But Robin, anything else you want to add?
Yeah, it's tricky, right? Because in primary care, at least, all of the clinics have their own instance of like we had all 3, we had Practice Solutions, the TELUS EHR, and Accuro. And when we were talking about, the unattached care clinic and more broadly, like regional primary care programming. And so we tossed around having it separate. Anyway, we really had to like be incredibly practical about it. So now, for example, we know nobody's going to make a big move at this moment with everything else going on to all be on Practice Solutions. Like I'm never going to convince my groups to do that at this moment, maybe in the future. But we need to look at things like how do we leverage when we think about supported attachment, for example. So we've got a record in one instance of Practice Solutions. Can we use Ocean to share part of that information and get it into the new physician's EMR? And then there's one group at the CHC who's working with a PDF reader AI tool. So it basically packages up that chart essentially and hopefully be able to transfer that, but in a way that's easily digestible by the physicians that they can trust. So we're working out that kind of just like really practical stuff. I mean, it's the idea, that announcement around a new provincial EMR is like, that sounds great. Good luck. I try to be, hopeful, but that one's a little bit of a mystery to me still. So yeah. Mhm.
Okay, I'm sorry, I'm sort of going to cherry pick the questions in the chat. So if I don't get to yours, this is something important to remember for our problem solving session next week. Please join that, and we'll also get to these other questions. There's a question by Dave Pearson. How does PCAT react to this model? And Jess Rogers also said to that, yes, how does it align with the provincial work? Have you been engaged with those folks at all, or how does that work, Joanne?
Yeah, thanks. There is a collection of all the neighborhood models that are existing in the province. They are being pulled together. Ian Cummings is I think leading that work of pulling that together. We have been in conversation with them. There is no defined model that exists. And so I think they're trying to learn from what exists within the network, who's doing what, and then coming up with some sort of shared understanding. We don't get the impression that they're going to mandate, it has to look like this, or this. But I wonder if there'll be some guiding pieces. The other thing is the OHTs in the province have come together, and there's a working group, and I think RISE is part of that as well, is looking at, okay, those that are starting out and wanting to do this, let's not recreate the wheel. Let's start from what we know and what's working and pulling something together as well. And so I think there's some good work there, but the PCAT team in particular isn't providing direction, if you will.
Okay.
I will say, Mike, with the unattached care clinic, I think we did get some feedback. I'm not sure, PCAT was a little bit like, that is not attachment. And we did get that question, like, you got two nurse practitioners just attach 1,600 patients. What are you doing? Kind of thing. They didn't say it that bluntly, but that was basically it. But our goal is to have that unattached program be an interim measure for when people don't have primary care, and have it be flexible and allow us to move resources around. What if one clinic has two physicians retire? So let's route some funding there so we can hold those patients until they can get reattached. So I think it's actually going to work out, although we didn't quite like I said, I don't know if we weren't actually that clever in the beginning. Like, that wasn't the intent, but I think that's how it's going to work out, and it's going to serve us well.
Yeah, and that's part of that larger picture, right? Of continuity of care too within the system of who and it's, they're getting active service while they're waiting. And we see this, that as we swap patients to the regions, this is another mechanism that we're utilizing in the scope of this work to make sure that people are cared for. No matter what is happening. And then future state, if new people are moving into the region, they automatically get care. And then we were able to build those files or whatever is needed for a clinician to take on that human or that family or whatever. So I think it's, maybe not so much like Robin said by design, but that's the trajectory. And then that it's emerged too.
Pauline, you had your hand up.
I did. I'm so appreciating listening to this today. So thank you. There's so many things that align, and even though we've traveled different paths, we're experiencing the same things. And I think what's been underestimated in all of this is some of the points that were just listed, is that attachment is not the end goal. Access, like all the things that we listed earlier today, like the continuity of care is the end goal, and that takes time. And the change management of getting people not to go to emerge and getting people comfortable, and those things that we put in transition to allow people to transition out of going to emerge to then access sort of either virtual urgent care or primary care services not in emerge, and then get them attached when we have humans, not only as patients, but as providers that we can attach to, has been underestimated in the time and the change management to move patients' behavior and trust to get to those values. And simply by sending somebody a letter, or being on a list does not do that. And I think, again, that's just sort of been underestimated, is the humanness and the human factor in all of this, the things that we can do with the resources that we have. And the equitable distribution of resources to serve the greatest good in each of our communities that we have, again, has been underestimated in the way that, and in the pace that we can move some of this change.
Well said.
Absolutely. Yeah.
Absolutely.
It's the culture, and I think it's even more robust because we have fewer like our clinicians our primary care clinicians are working in hospital, for example. So we even have more of a design where people are driven to hospital care in a way that is, and the expectation that it's okay, right? We have 8 hospitals. It's fine to go there after hours. I don't want to take off time from work and go to my primary care provider and those types of things. So we've been talking about this a lot because we really have to really think about what's our communication strategy to shift the culture to around this, but not only that, but to wellness. How do we look at wellness and keeping people well versus, the sick care sort of ideology that we have today? And so there's a real, to the value statement, I think you've really hit it on the head. What we're faced with, it's going to be tough.
Well, as always, wonderful conversation. And as always, we don't have enough time. We got a couple of minutes left. I just want to let you know what's currently happening. We're talking with Jess Rogers at AFTO and DP Sur at the Ontario College of Physicians about how we can coordinate our work. There's a lot of people and organizations supporting this type of work out there, and RISE is going to make sure that we coordinate with everyone. The Alliance is doing work also in this area. So please stay tuned for what that coordination will look like. For our next session, oops, sorry, I've got the chat box right in front of my screen. We'll put these questions onto paper and bring them to our weekly problem-solving session, which will be I can't remember the date. It's going to be, Leslie, help me out here.
Our next session is July. So our next session is July 16th around staging the work. So the questions that we get from today that we weren't able to answer, what we'll do is that OHT shared space that we put in the chat box, and thank you, Steve, for putting it there again. We will post the questions and answers there for you.
Okay, terrific. And then after that session, we'll have our first peer problem solving session. I thought we were having one this month, but I made a mistake on that. Is there anything else after that, Leslie?
Nope, just our next session will be July 16th. So it'll be similar to today, but we want to continue to adjust based on your feedback, including the formats. We're going to focus on staging the work. So all those different drivers that Mike shared about, talking about how might you want to think about where to go next, or what sequence of the drivers might you want to consider as you think about building a plan or continuing to adjust your plan. And then the second session following that, July 23rd, that is going to be just for OHTs and PCNs. We heard loud and clear that you want some time with just your peers and EDs running clinics to work through the details of the problems related to staging the work. So those are the next two sessions. And thank you, Steve, for putting that in the chat box as well. As always, please feel free to reach out to any of us between sessions as you have questions, or post it in that OHT shared space, and we'll be happy to answer those for you. We hope you have a great afternoon, and thank you so much to Robin and Joelle for coming and sharing their learnings, and for all of you for participating today.